You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
When every decision matters, you need trusted medical intelligence. Medscape AI synthesizes peer-reviewed evidence and Medscape's expert-validated content in seconds, delivering clinically verified answers you can trust. Join over 13 million Medscape members on the world's leading platform for clinicians. Start using Medscape AI on the web or in the Medscape app. Medscape AI, trusted medical intelligence.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 17th, 2026. This week, dual antiplatelet therapy post-stent is back in the news, a practice-changing trial in VTE therapy, new knowledge in sudden cardiac death, heart failure definitions updated, and a dumb decision by NICE in the UK. First topic is antiplatelet therapy after stenting. Just when I thought the consensus for post-stent management was to shorten the period of dual antiplatelet therapy, or DAPT, comes the DAPT MVD trial, where more than 8,000 patients with drug-eluting stents and multivessel coronary disease were randomized after 1 year of clopidogrel and aspirin or ticagrelor and aspirin to another year of continued clopidogrel or aspirin alone. It's a super interesting trial design, and external validity concerns come to light. The trial was done in 97 centers in China. I like the trial design. It's neat. All patients had to have a drug-eluting stent. About a third of these were during an MI. They had to have multivessel disease, and they had to be on dual antiplatelet therapy with either aspirin clopidogrel or aspirin ticagrelor for 12 months. Then, at 12 months, when most doctors would transition to single antiplatelet therapy, patients were randomized to aspirin alone or aspirin and clopidogrel for another 12 months. The primary endpoint was a MACE composite of CV death, MI, or stroke. The primary safety endpoint was clinically relevant bleeding or major bleeding. The trial enrolled more than 8,200 patients, which is a lot. Patients were young, at 60 years old, 30% female. These were thin patients, BMI 25, and the LAD was involved somehow in more than 90%. So the results: a primary efficacy endpoint occurred in 222 patients in the DAPT group and 266 patients in the aspirin monotherapy group. That's 5.8% versus 6.8%. Hazard ratio 0.82 with 95% confidence intervals 0.69 to 0.98, and a p-value just dipping under significance at 0.03. The 1% absolute risk reduction was driven almost completely by fewer non-fatal MIs. CV death and all-cause death were nearly identical. Clinically relevant or major bleeding occurred in 1.4% versus 1.5%, so that hazard ratio was 0.89 in wide confidence intervals and a non-significant p-value. So the extra antiplatelet therapy, clopidogrel and aspirin, decreased MACE but did not increase bleeding. A couple of notes on the results. The benefit seemed to appear after 6 months of extended DAP, and most of the MI events occurred in non-target coronary segments. Also interesting was that the rate of stroke in both arms was greater than the rate of MI, and I'm not used to seeing that, especially in 60-year-olds. Usually in these MACE endpoints, the MI signal is greater than the stroke signal. So my comments: every time I look at one of these studies, I get more confused. And I really don't feel bad about it anymore, because now multiple experts also express curiosity. For instance, UK interventionalist Dr. Nick Curson tweeted, quote, "This field is genuinely bewildering, even if you have worked in it for 30 years, 2 exclamation points. Now, here we were, seemingly moving to a less is more, shorter duration of DAPT. This evidence in these patients, in this trial environment in China, shows clear superiority of another year of DAPT, but over aspirin, not clopidogrel. Now, what I mean by saying these patients in this trial environment is that the trial was enriched with patients at high risk for ischemic events. They had multivessel coronary disease, but they were also young and been on DAPT for a year without incidents, and therefore they were also low risk for bleeding. And this is the crux of this decision point, right? Previous trials and common sense holds that DAPT will reduce ischemic events, but at the cost of increased bleeding. The art of medicine is picking the patient who would benefit from longer or more intense antiplatelet activity, but is less likely to bleed. And I think this trial really did this in spades. They enrolled high-risk patients based on multivessel disease. Many had diabetes, many had acute coronary syndrome, but they were also young, and they had already survived a year of DAPT unscathed. On Twitter, Dr. David Cohen noted from Table 1 that most would have had a high DAPT score. Of course, the DAPT score is discovered and validated by the group of Dr. Robert Ye at Beth Israel Deaconess Medical Center. To me, though, the biggest limitation for translating this trial is not the highly selected patients, as these seem to be pretty common to me, but the choice to use aspirin as single antiplatelet therapy. What if the single antiplatelet therapy was clopidogrel alone versus clopidogrel and aspirin? More and more, I often see clopidogrel being used as the single antiplatelet agent. And this is somewhat based on evidence, right? In the host exam trial, the original 2-year results showed that clopidogrel monotherapy versus aspirin monotherapy after PCI significantly reduced the composite of all-cause death, non-fatal MI, stroke, and readmission for ACS and bleeding. And it was a 2% reduction, 5.7 versus 7.7%. Recently, at ACC, the 10-year extended follow-up was published in Lancet, and this reinforced this. Clopidogrel monotherapy compared with aspirin monotherapy was associated with a significant 14% lower rate of the primary composite, and that was ischemic and bleeding outcomes, though all-cause mortality was not changed. So the teaching points, I think, are that in selected patients, extending DAPT may be a wise choice, though I would want confirmation of this in a non-Asian population. That's because genetic differences in clopidogrel metabolism are there, as well as the very low obesity rates in this trial versus everywhere else in the world. Okay, teaching point B, trial translation heavily depends on who the patients were in the trial. Here, the selection was for high ischemic risk and low bleeding risk. This data surely does not apply to elderly, high bleeding risk patients or lower ischemic risk patients. And I guess third point, I'm perplexed by the high stroke rates relative to MI. I don't have an explanation for that, and maybe you do. And finally, I have to add this, and I'm sorry, but none of these post-stent decisions have to be made if stents are not used. In ACS, we know revascularization is beneficial. But in chronic coronary disease, it's important to reiterate the lack of evidence that revascularization improves clinical outcomes over medical therapy. And the evidence that revascularization reduces angina is also precarious, depending on if you like Orbita 1 or Orbita 2. Okay, let's move on. Aspirin proves its mettle after hip and knee replacement. Now, New England Journal of Medicine has published a really, really nice Canadian trial called EPCAT-3, EPCAT-3, looking at aspirin alone for VTE prophylaxis versus 5 days of rivaroxaban 10 followed by aspirin in post-orthopedic surgery patients who had hip and knees. Now, the post-orthopedic surgery VTE literature is almost as messy as antiplatelet therapy after stents. Even though VTE prophylaxis is peripherally involved with cardiology, I cover this trial because it's A, close enough, B, it's a great trial that used non-inferiority in the correct way, and the results surprise me and should probably change practice for millions of people who have orthopedic surgery. Now, the background is simple. VTE and PE are very bad complications of knee and hip replacement, and the current practice of VTE prophylaxis is all over the place, and it includes aspirin use, DOAC use, enoxaparin, and even warfarin. Rivaroxaban is commonly used for prophylaxis after arthroplasty because clinical trials and meta-analysis have shown that rivaroxaban is more effective than low molecular weight heparin for preventing VTE, but it's potentially associated with more clinically important bleeding complications. Now, the same investigators that did EPCAT-3 did the EPCAT-2 trial, which evaluated the use of aspirin after a 5-day course of rivaroxaban in patients who had arthroplasty. EPCAT-2 showed that the combination of rivaroxaban followed by aspirin was at least as safe as effective as rivaroxaban alone, with a frequency of VTE of 0.64% in the rivaroxaban aspirin group and 0.7% in the rivaroxaban alone group, and that was obviously not statistically significant. So the Canadian team, I think, boldly decided to test aspirin alone. In 15 academic centers, more than 5,300 patients who are post-hip or post-knee were randomized to aspirin alone or rivaroxaban for the first 5 days. Then all the patients received further thromboprophylaxis with 81 milligrams of aspirin daily for 9 additional days after knee and 30 additional days after hip. Patients were followed for 90 days for symptomatic venous thromboembolism, which consisted of either proximal DVT or PE, and that was the primary effectiveness outcome, and for bleeding complications, which was primary safety. The non-inferiority margin for aspirin alone as compared with rivaroxaban aspirin was 0.7 percentage points. Notable, I think, was that the expected rate was 0.7% in the control arm. So if the margin is 0.7 and the expected rate is 0.7, they basically are saying non-inferiority is there if it's less than twice as bad or 2.0. And you can argue about that, but these are low-frequency events. The patients enrolled were young, 66 years old, slightly less than half were female, and hip and knee surgeries were balanced, about half and half. Using the STOP VTE score, which I don't know about, but they wrote about, more than 90% of enrolled patients were scored as standard VTE risk, and only 3% of enrolled patients were considered high VTE risk. And the results, 0.48% primary outcome in the aspirin arm, 0.45% in the rivaroxaban group, and so the difference is about 0.02%. And it had an upper bound of 0.39%, which is less than the 0.7 non-inferiority margin. So aspirin alone, just aspirin, was declared non-inferior to rivaroxaban. Now, what about bleeding? Major bleeding or clinically relevant non-major bleeding was 1.66% with aspirin, 2.04% rivaroxaban, and so that minus 0.38 lower percentage points lower rate of bleeding was not statistically significant, but numerically lower in the aspirin arm. So non-inferiority was also met when they did an on-treatment analysis, which is, of course, the most conservative analysis in a non-inferiority test. They also looked at symptomatic distal VTE, that is, clots below the knee, and here it was very similar results, 0.55 versus 0.45, and then they added this to the composite, and they also looked at the non-inferiority if they had included that in the primary endpoint. And here the upper bound gets to 0.68%, but that's still under 0.7. So even with adding distal VTE, it was non-inferior. In the discussion, the authors write that in the Crystal trial, this was published in 2022, Crystal was a cluster randomized crossover non-inferiority trial that compared aspirin alone with enoxaparin in patients undergoing hip or knees. The trial was stopped early after an interim analysis showed a higher rate of symptomatic VTE in the aspirin group, and it was driven, though, by an increased risk of distal deep vein thrombosis. The event rates in EPCAT-3 were lower than those in some previous trials that assessed the use of aspirin alone in this population. In the Crystal trial that I just mentioned, the frequency of proximal deep vein thrombosis and PE in the aspirin alone group was 1.3% as compared with 0.51% in EPCAT-3. So the authors write that, quote, applying the STOP VTE risk assessment model to our patients, The vast majority were classified as being at standard risk. It was only 3% of the patients classified as being high risk. As such, they write, an individualized strategy should be considered if a patient is identified as being at higher risk for VTE. So my comments, come on. This is the kind of clinical research that we need more of. The Canadian government funded the trial. The goal of the trial was to answer an important scientific question. Neither the authors nor the funders knew what the result would be. Therefore, my friends, the purpose of this trial was to actually answer an unknown question, not simply sell more devices or drugs. I cover trials like this because it so starkly shows the difference between a marketing exercise and true science. Also, I say non-inferiority was the proper test here. Aspirin is less costly. It's easier to take than rivaroxaban. You don't need a prescription. You can just go buy a bottle of baby aspirin. So, if aspirin, which is like pennies, is just as good as DOAC, then that is important knowledge, and in this case it was. The authors demonstrate non-inferiority in both the intention to treat and the as-treated group. They also showed non-inferiority if you include distal vein thrombosis, which was the driver in the previous crystal trial. And also, bleeding rates were numerically lower in the aspirin arm, but not statistically superior. Still, though, aspirin is enough of an advantage that I see this as fairly definitive data. Now, the one question I have is that the authors do not publish results on the relative risk differences, only absolute risk differences. And given the very small number of events, this seems fine, but you'd technically like non-inferiority to be met with both a rate ratio and risk difference. I worry here that given the small number of events, the confidence intervals would be very wide on the relative scale. I mean, you're dividing 0.48 by 0.45, and the trial, despite its large numbers of enrolled patients, may be slightly underpowered. That said, the number of events, 12 versus 13, is hardly different. Bleeding rates were lower, and aspirin is so much easier than rivaroxaban for the millions of intermediate risk or low risk patients who have hip and knee surgery worldwide. I say congratulations to the Canadian team and Canadian government, and you can save this trial and save this manuscript as an example of clinical research that tried to answer an important question and nobody was selling anything. All right, new and old knowledge in sudden death. Jack has published two important autopsy studies from the UCSF POST group. One is titled Sudden Cardiac Death and its Relation to Previously Diagnosed or Occult Cardiac Disease at Autopsy, and the other paper is titled Sudden Cardiac Death Due to MI with Obstructive and Non-Obstructive Coronary Arteries. Okay, so first off, the post-SCD group, that's Postmortem Systematic Investigation of Sudden Cardiac Death. This is a prospective countrywide study using autopsy to adjudicate presumed sudden cardiac death as cardiac, that's arrhythmic or non-arrhythmic, or non-cardiac causes, with trauma deaths as the reference control deaths. Okay, in the first study, they assessed prevalence, that is the sensitivity of diagnosed risk factors. Risk factors like ejection fraction less than 35%, heart failure, previous MI, or syncope, and they assessed this among arrhythmic, non-arrhythmic, and reference trauma deaths. Among arrhythmic deaths without diagnosed risk factors, they assessed occult cardiac pathologies, including dilated cardiomyopathy and healed MI. And the main findings of this first paper, of 877 presumed sudden cardiac deaths, 58% or 513 were autopsy-defined arrhythmic deaths, of which 166 or 32% had diagnosed risk factors. The mean age of these patients, 64, 77% men. And therefore, sensitivity of risk factors for arrhythmic death was a measly 32%. 32%, that means 2/3 did not have normal risk factors, such as low EF. Another third of these autopsy-defined arrhythmic deaths had occult MI or DCM, dilated cardiomyopathy, and another third were younger patients, about 56 years, who had less cardiac pathology than arrhythmic deaths, with occult MI or diabetes, but still had increased heart weight, larger LVs, and more significant coronary disease, but similar fibrosis. I just said a lot, but I think it's worth just taking a look at the paper and look at the central illustration, or at least I'll try and describe it to you. It's really a nice figure. It's shown as an iceberg. And a third above water who had normal risk factors like low EF, heart failure, prior MI, and syncope. These are the patients that get ICDs. A third of the iceberg was just below the surface, had occult MI or dilated cardiomyopathy. And another third had intermediate cardiac pathology with some CAD and some LVH, and less than 1% of these patients at the bottom of the iceberg had a normal heart. The main discussion point is that 2/3 of community arrhythmic deaths were effectively missed by regular sudden cardiac death risk factor stratification. Yet 1/2 of these had undiagnosed MI or dilated cardiomyopathy, and yet another half still had some substantial intermediate cardiac pathology, such as chronic CAD or left ventricular dilation, and that's compared to trauma death. So the authors write, quote, "To move the needle against the global sudden death epidemic in the modern era, prioritizing identification of, quote, silent disease in this vulnerable population is critical." Now, while many listeners may be shocked to hear how poor traditional risk factors were in identifying actual sudden cardiac death, this is not new knowledge. I mean, well known from the turn of the century when ICDs came to popularity was the observation that while patients with low EF and heart failure have an increased incidence of VF relative to people with normal EF, the vast majority of sudden cardiac death in the community in absolute terms occurs in people with no known heart failure or LV dysfunction. So this data kind of reconfirms very old data. And I will cite a 1997 American Journal of Cardiology paper with the first author, Robert Meyerberg, and a beautiful graphic. And in that paper, it just shows that most sudden cardiac death occurs in patients with no known left ventricular dysfunction. So in the companion paper in JACC, looking at sudden cardiac death due to MI with either obstructive or non-obstructive CAD, the authors show that of the 583 autopsy-confirmed sudden deaths, 41% were due to MI, and of these, 90% were acute or healed myocardial infarction with obstructive coronary disease, so-called MI from CAD, and 23 or 10% were acute MI with non-obstructive coronary arteries, so-called minicoa. And the LAD and RCA were nearly equally involved in the sudden cardiac death. And I think the main take-home from this observation is that the old teaching had that 80% of sudden cardiac death were due to MI, but in this paper, sudden cardiac death due to MI accounted for only about a quarter of all sudden deaths and 41% of autopsy-confirmed sudden cardiac deaths. Of course, the second finding was that MI due to no obstructive coronary disease accounts for 4% of all autopsy-confirmed sudden cardiac deaths and 10% of sudden deaths due to MI. And that's kind of interesting, but small numbers. Also notable is that sudden death with minicoa, MI with no obstructive coronary disease, had more free wall rupture and pump failure relative to MI from CAD, where most of the sudden cardiac death was arrhythmic. So overall, taken together, the two papers, I would say the three messages are that the 80% of SC death is due to MI teaching is roughly cut in half. Now it appears that sudden cardiac death stems from a much more heterogeneous basket of causes. I think this is good news and bad news. It's good because we're doing better with CAD, but bad in that diagnosing and predicting these heterogeneous causes is going to be super hard. I would say maybe impossible, which leads me to the second message, which is sort of old. Current risk stratification criteria catch only 1 in 3 people who will die suddenly from arrhythmia. I mean, we love to think that ICDs are great and life-saving, and they sometimes are, but the truth is that we miss most cases of sudden cardiac death by just using LVEF. Many more people die suddenly with minimal heart failure, minimal disease, not anywhere near ICD eligibility. And the third message is hinted at by the authors, but I want to emphasize in the strongest terms None of this data comes close to suggesting that we should be screening for occult disease. It would be an unmitigated disaster to start doing extensive screening, say with MRIs or echoes, to assess sudden cardiac death risk. Recall that while these are large autopsy series, these few hundreds of cases represents a minute fraction of heart disease and sudden death in the community. And the vast, vast, vast majority of people with occult MI or dilated cardiomyopathy or hypertrophy do not have sudden cardiac death. So if a disease prevalence is this low, even a screening test with a 90% sensitivity and specificity would be a false positive detection machine. Now, I'm not saying that research should stop. I mean, we should look at things, but perhaps AI and imaging and gene profiling someday will sort out true from false positive, but we are nowhere near that now. SCD is and will likely remain a highly stochastic event that will likely defy modern prediction techniques. When I read these papers and I see survivors of sudden cardiac death in the hospital, what comes to mind as the obvious best intervention now is what they do in Northern Europe and Scandinavia. Have better community resuscitation. Teach CPR in schools and churches. Put AEDs everywhere. This treatment after the fact is a high value intervention. Now, I know for the AI people, we've never had AI before, so it's hard to know what the future holds. We couldn't imagine medicine before the internet because we didn't have an internet. But I seriously doubt that AI is going to bust the mystery of sudden cardiac death. I think AEDs and CPR education are the answer for now and the next decade. All right, next topic is heart failure diagnosis. Numerous experts in heart failure have released the, quote, second universal definition of heart failure. Now, I didn't really know there was a first universal definition of heart failure, but this document is 16 pages, has 71 references. Key changes are a few things. First, they reaffirm the four-stage system. Stage A, get this, at risk, no structural disease. Stage B, pre-heart failure. That means you have structural or functional abnormalities but no symptoms. Stage C is symptomatic heart failure. That's what we deal with. Stage D, refractory and advanced heart failure. Now, more on this staging system in a second. Another major change of the second universal definition is moving away from strict LVEF cutoffs. Rather than rigid ejection fraction thresholds, heart failure in this document is now grouped into HFrEF, HFpEF, and heart failure with improved ejection fraction. Now, the third theme is there is a new universal classification of causes of heart failure. The authors introduced a 16-category system for heart failure etiology. I don't really care how many categories are, but I think it's kind of important to outline whether there's ischemic heart failure, hypertensive, valvular, infiltrative, toxic, heritable, pregnancy-induced, high output. And this move is intended to improve consistency in research, registries, but also clinical care. And it replaces the overly simplistic ischemic versus non-ischemic split. Finally, the authors address trajectories of heart failure, such as distinguishing improvement that EF gains despite persistent abnormalities, or remission, which is normalized EF with minimal symptoms, and recovery, sustained normalization, and they say that this is reached only by a minority. This is also important because once someone is diagnosed with symptomatic heart failure, that diagnosis is considered permanent, even if their condition improves, and this doesn't seem right. So, comments. I was going to get sideways about the ridiculousness of having two of the four stages of heart failure as at risk and pre-heart failure. I mean, any staging that includes at risk of disease is silly because not dying and getting older puts you at risk of nearly every disease, including heart failure, AFib, CAD, cancer, dementia, immobility, just to name a few. I also don't love pre-disease diagnosis, so pre-heart failure, because just having LVH or dilated left atrium or tricuspid regurg should not land you in a heart failure staging category. If we continue on this trajectory, with at-risk and pre-disease categories, there will cease to be any healthy older adult, period. But that said, there is also a lot to like about this document. I mean, we have to do something about the terrible name congestive heart failure. People, for instance, I see come in with heart failure and reduced EF, and they have AFib. Now, you correct the AFib, and 3 months later, they have a normal ejection fraction and no symptoms, and their ECG is normal. These patients should not have a heart failure diagnosis. So I like the trajectory-related categories. Heart failure recovery or remission is a nice change. I also like the idea of moving away from ischemic versus non-ischemic because non-ischemic causes are so hugely heterogeneous. A person with amyloid is clearly different than someone with hypertensive HFpEF. I'm also glad the document is only 16 pages. That's fairly brief, and so I would say overall I like the document. I like the new changes. Okay, final topic today is NICE, the National Institute for Health and Care Excellence in the UK, has made a dumb decision. They've recommended the new nonsteroidal mineralocorticoid receptor antagonist for heart failure, finerenone. Now, I'm no expert on UK healthcare, but I do read, and there is a bit of a problem with access and cost. Then this week I read that NICE has recommended finerenone in final draft guidance as a treatment option for adults with symptomatic chronic heart failure with preserved or mildly reduced ejection fraction. Now, I remember when I visited Scotland a few years ago and the late Dr. Andrew Flappen was telling me how mad he was that NICE had recommended ticagrelor based on the flawed Plato trial, which was ticagrelor versus clopidogrel. And I've covered that a bunch, but suffice to say that there were so many flaws in that trial that Dr. Flappen did not feel, nor do I, that ticagrelor was superior to clopidogrel, and he was angry about how much this would cost the British taxpayer. And I think this story is similar here with finerenone, because the Fine Arts heart failure trial found that finerenone beat placebo for the reduction in CV death and heart failure events by 16%. The benefit in Fine Arts was driven by 8 heart failure events with no difference in CV death or all-cause death. The difference, the absolute difference, was small in absolute benefits, 2.8%, but that's not the main issue with the Fine Arts trial. The main issue with this trial and this drug is it was not compared against spironolactone or eplerenone. So we don't know, NICE doesn't know, the British taxpayers don't know, the American taxpayers don't know if the less costly drug would be just as good or better. Of course, my friends, this is what you get when drug companies and academics with conflict of interest and relationships with drug companies design and run the trials. Instead of knowing whether the new mineralocorticoid receptor antagonist is better than the old mineralocorticoid receptor antagonist, we get a comparison to placebo, and that doesn't help us. It doesn't help the payers of healthcare. It doesn't help the patients who might benefit or not from these drugs, and I think it's a failure of evidence-based medicine writ large. And so that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review. We're getting close to 1,000 reviews on Apple iTunes, so I'm excited about that. If you disagree with anything I've said or have something to add, please let me know. I always appreciate listener feedback. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.